quite high, but also UHC has been rolled out in all the 47 counties. About 6 of them have launched it, about 41 still yet to go. But we're still talking about the tenets of it all: affordability, accessibility, and quality of healthcare. Now we're talking on the issue of affordability. And Professor Olive, you're coming in this conversation. How do we ensure that healthcare is affordable to the people?
Thank you, Trevor. What we have seen in the hospital is that 80% of the patients coming are coming under NHIF. 80%. The others are coming under either paying cash or through the private insurance. So you can see if we can really improve the NHIF, that is where the majority of Kenyans are. And what, in my opinion, needs to be done, we need to make sure that all the services are covered, and not just covered, but covered adequately. We are finding situations whereby, Trevor, you come, maybe you need radiotherapy, but the amount covered is like, if you need 20 sessions, maybe after 10 sessions, then you are not able to go on. Now, that is not helping a lot, because then it means the disease is not cured, or, then the disease will progress. So I think we need to look at all those services, make sure they are comprehensively covered. I've seen cases where people come for chemo, and then after several sessions of chemo, they can't continue, and they can't afford. So we need to make sure that, just for it to be comprehensive, make sure the treatment is complete, and then make sure that the patients don't have to add. Again, something else that is happening, which we need to, maybe as a ministry, we need to look at. You are prescribed medicine. Then you find that for your limit, you can only get half of that medicine. So they come and tell us, this is a prescription, but NHIF is covering maybe 80% of it. I don't have 20% to add. And then what does that do to the patient and the recovery and the outcomes? So we need to look at all these services, make sure they are properly covered and comprehensively covered. So that's a big deal that Lenai will talk about. But Prof, how are you dealing with it in the UK? I keep insisting on this because I know most of the time the UK has a very different system, like you mentioned. But how are you ensuring that this is affordable to the masses?
Well, the first principle of the National Health Service is it's free at the point of use. So we don't have a system of co-payment. I think it's probably fair to say that globally, and this is where I think in our partnership it's quite useful when we talk about benchmarking, what's the best way of ensuring affordability? And there are multiple different systems of how you pay for healthcare around the world. Some are entirely free at the point of use, like in the UK, but it still needs to be paid for. It's paid for by the taxpayer. So there are two questions of affordability. One is affordability for the patient when they present or when they need treatment, and then one is affordability for the economy. And clearly the two are linked, because healthcare and high quality healthcare isn't cheap. So it has to be paid for at some point. In Europe, it's a mixture of, if you like, public provision and an insurance system. And in the US, it's predominantly driven by an insurance system. I think in all of these concepts of affordability, I think the one thing that we need to move away from is, and you see this quite often in the US, you can be one medical bill away from bankruptcy. So I think there are those overwhelming one-off costs that it's really critical to afford as a first step, and UHC, I mean, the details of that I'll leave to the experts, will address that. What I would say, and part of how we're working together in partnership in terms of affordability, one is that, to get back to the point of prevention and early detection, not only is it better for the patients, it's also possible to cure, and it's cheaper. So there is no doubt that is what all health systems are looking to do. Now, that's not easy, because it requires a well-trained health workforce, it requires access, as we spoke about. So this networking model is really important, because you want to get out to the patients when they have early disease before they present at hospital and need radiotherapy or whatever else of these fantastic facilities that Professor Magenda's hospital provides for the whole nation. And the other thing I'd say about affordability is we need to make sure the treatments we're giving are effective. Do they work? That's about the international benchmarking. Are the treatments that we give to a predominantly white population, for example, in the UK or the US, do they work in a Kenyan population? So there's a lot of really important research that we're doing in partnership to address that question. Because if you're giving an expensive drug and it doesn't work, then that's money wasted and it doesn't work. So it's not good for patient outcomes. So there's clearly then a further issue about the cost of drugs, for example, particularly for cancer, can be very expensive. That's an entirely different issue. But I guess my summary position is there has to be payment for it somewhere, and probably a mixture of some co-payments with support for the very poorest in society, effective use of the private sector as well. It sounds like that's exactly what UHC is trying to do with that mixed model. But as I said, because there are multiple different models around the world, there is no one magical answer for this. And I think very important first steps of UHC being rolled out. It may need to be adapted as you find out that some things don't work as well as others do. And again, that's what we're here to try and sort of provide support around, so that the best access for everyone in Kenya. All
right. Let me bring in Professor Kibwana back on this. And before we get into the issue of accessibility, because accessibility is not just about the brick and mortar, right? There's also the people who work there, and that has always been the biggest challenge. Would we really address this if we just stuck to the Abuja Declaration, where we said we'd do 15% of our national budget to healthcare?
I think that's a very important point, because even nationally one can say there is underfunding of the health sector, because currently we are spending like 2.7 US billion shillings on this sector, which is about 10% of government spending. And so if we go to the 15%, it means that some of these issues that we are addressing about the brick and mortar, about the staff, about the equipment, about the drugs, all those issues will be significantly taken care of. And of course, health is basically a county function. And so one has also to look at how does money from the national level, in terms of Afya House, how does it percolate to the counties, so that there can be spending there to ease the disease burden. So definitely, that is one important thing to be done, to make sure that there is more money, coming to the county level, so that we can really convince our citizens that whether it is the staff, whether it is the facilities and all that, it equals what will be provided for at the private hospital level. And just permit me very quickly to say, for us, when we were starting universal healthcare in our county, in a subnational government, the package was for everything that we offered. Whether you are going to be operated, whether it's even chemotherapy, cancer treatment, working with the First Ladies Initiative and the ICI, Roche, SCF, working with all those. We made sure that people could actually be treated for very, very, very little. And even during COVID, because we had a COVID center, we were actually able to treat people for the 500 shillings then. And maybe because we had started it that way and we couldn't change it midstream, we still went through helping people when they had paid very, very little, although it also became apparent that there is a lot of burden on the county budget. But the point I'm trying to make is you can have a good package, you can provide most of these services, and it can be cheap. It doesn't have to be very expensive as such. It is affordable. And the accessibility is, especially when the facilities are better and better, and because more money is committed to them. And if we go to the 35% for devolved funds, that definitely will give headroom for particularly improving the health, because when you improve the health, you improve the economy. People are better, they work better, and the economy expands, and you bring the money to the health sector. So one has to look at that big sum, which is dedicated to the health sector.
Okay. Dr. Linai, there are some issues that were raised by Professor Mugenda on NHIF when some money, it doesn't cover all the therapy sessions, the chemotherapy sessions that people require. Sometimes it covers only 80% of the drugs that you need and you can't afford the other 20% and it's a full dose. How do you address those issues? And also as you address that, should there be a policy shift whereby doctors who are in government institutions are not allowed to have private facilities? Because we've seen situations where you go to a doctor and even though you might access some of the medicine there, they'll refer you to a private facility as well because it's also a money-making venture. So let's start with the NHIF one, then come to the doctor.
Thank you, Trevor. I think what needs to be clear is when we are told to choose the facility for NHIF, I think people need to know it's not just a matter of choosing maybe the one which is near you or so. They need to know the facility that is near me, what kind of cover are they having? Is it a comprehensive cover or is the one that we need to cost share? I think that is where we need to start. So wherever what we call the national scheme are choosing NHIF, they need to have that behind their mind. Because there are two types of cover, or three types of cover in NHIF. There is the one that you need to cost share. There is the one which is comprehensive, you don't have to pay anything. And usually their capitation or what they get from NHIF is a bit higher. Yeah. So we need to be aware of that. So it's not just a matter of just choosing a facility. So they need to ask, what type of cover of NHIF do you as a facility have? If it is comprehensive, let's go for that. If it is not, then they need to rethink about that. Yeah. Now, we have given leeway for those types because there are those facilities which prefer maybe that kind of cost sharing. So I think the first point is point of choosing NHIF. Mm-hmm. Now, in addition, again, of course, why are we cost sharing? Why are we having cost sharing? Of course, no. There are those who can be able to afford to pay something. And as I said, we have started looking at the issues of those who cannot be able to pay, what we are calling the indigent. We are already paying for them so that even when they go to the facilities or any facility, they are covered for. Their data is already there. Yeah. They are covered for comprehensively. So in terms of the issue of looking at the schemes, I think that needs to be very, very clear, that there is the national scheme and the civil servants. Now, what have we done for the national scheme? Of course, earlier on, there were things like dental and optics that were not there. But in the new NHIF reforms, we have introduced issues of dental and optics to be covered for everyone, especially the national scheme. The national scheme is these other non-civil servants. Yeah. So that is being covered. What about for civil servants? What you realize is that there are two groups of civil servants. Yeah. There is the national civil servants, and there are those who are in the county staff. Now, for the national civil servants, they have already entrenched or taken care of what we are calling the comprehensive cover. Now, for the counties, it's between NHIF and the counties to agree on how to cover the people. The staff of the counties. Now, some counties have gone to that level of taking the managed scheme, which is a comprehensive cover for their staff. But you find also some counties, what they are doing, they are having a hybrid, whereby they are taking both NHIF, the normal one, and apart from that, also looking for a private cover. But what we are urging the counties is they consider this comprehensive package for NHIF, which is taking care of everything, including even coming to the hospital of Professor Mugenda, they'll be taken care of. Okay. Now, on the issue of private facilities and doctors in public, this is an issue which has been on discussion for quite some time, but it's unethical, especially in the practice. I am a doctor myself, whereby when you see a patient and you deliberately prescribe and deliberately make sure that services which are within the facility of a government, you are making sure that they are going to seek them outside there. To me, that is unethical. It should not be done. And surely it should not be entertained.
Yeah. So this becomes entirely a moral issue, Dr. Lenai, because now the problem is, as a patient, and the doctors have a very interesting handwriting. They write things that you can't even read. So I wouldn't even know whether that medicine is actually there or not. I mean, I'm at his mercy. He says I have to go to a private facility out there. That's exactly what I'll do, because I can't question. I can't tell him that I know this drug is with you here. I wouldn't know. So how do we help the patients?
What you realize is that, as I said earlier on, it starts with the individual. I think the issue of being ethical is very, very key. And in our medical practice and the Hippocratic Oath, I think we are clear that at the end of the day, the life of the patient becomes priority. But all that is prescribed or you are sent out, is it true or false? We cannot be able to say.
But why don't we have a policy then that if you're in the public sector, just stay in the public sector? If you're private sector, in the private sector. For example, I can't be anchoring here and then in the evening you see me in another TV station.
I think that's a matter to be considered. That should be looked into.
Okay. Professor Oliver, how do you think we should handle this issue exactly?
I think I fully agree with you, Trevor. I know it's not an easy topic to talk about, but I think eventually that is what needs to happen.
Yeah.
You know, if you're in the public sector, be in the private public sector, because we have seen where you're in the public. In a public hospital like ours, you're being paid, but then you're also working for other private institutions. And of course, we are denying Kenyans the service. So I think that's a policy issue. And I think the government can come up with a very firm policy so that does not happen. The other one is a policy on the drugs, as you said. It's a question of also us coming up with policy. If you are coming to a hospital, for example, there's a policy that you buy the drugs from there. And everybody knows and is enforced. So I think those are some of the things we need to do. But coming back, Trevor, to the question of access, I think the question of the training and is important. And I think we need to have a policy where doctors are trained en masse. We are finding, if you look at the oncology, there are very few oncology doctors. So what can we do as the central government and county governments to make sure maybe the next 5 years we have a plan where we are saying we are going to train and have like 500 oncologists, in Kenya, because now we are sharing the few who are there, and the patients are really suffering. So I think we need a policy, and I'm sure the ministry is big about it. I heard about it yesterday from CS, where he was saying we need a program. That airlift that was there some time back. Something like that, where we say we are going to have 1,000 oncologists, 1,000 renal specialists, and then we say maybe the next 5 years we are going to have all these people. Because then if they are available, then